Hello, my name is Macy Northup. I'm a speech pathologist and I'll be presenting on Sjogren syndrome today. So, what is Sjogren syndrome? Sjogren syndrome is an autoimmune disorder. It tends to accompany other disorders and it's often mistaken for other syndromes such as lupus. It affects the whole entire body, so it causes pain throughout the entire body, which I'll talk about later. But the two main symptoms of Sjogren syndrome are dry eyes and dry mouth, which I will go over in the next couple slides. So a historic timeline of Sjogren syndrome kind of gives you an idea of how Sjogren syndrome was developed. So many researchers came close to finding all of the symptoms. However, each researcher kind of built upon the next until eventually Dr. Henrik Sjogren eventually made the diagnosis. So Leber was the first one to notice dry eyes and the irritation of the cornea. Dr. Joanne Mulizik noticed dry mouth and difficulty swallowing and difficulty speaking. And then in 1930, Dr. Henrik Sjogren kind of tied both of those symptoms together. So the dry mouth and the dry swallowing, he found one woman with both of those symptoms and then eventually found 19 cases of the same symptoms, ultimately made the diagnosis of Sjogren syndrome. So the diagnosis and prevalence. So typically a rheumatologist diagnoses Sjogren syndrome. However, optometrists and dental assistants can find the red flag, so the dry mouth and the dry eyes. The diagnosis is made typically through a blood test. A lip biopsy is done because a blood test isn't always accurate, so a lip biopsy can be done. However, the most common way of diagnosing Sjogren syndrome is through just a compilation of all the symptoms, so using the symptoms to make the diagnosis. So Sjogren syndrome is rare. About 4 million Americans present with Sjogren syndrome. It affects women over the age of 40 more than men, significantly more. And it affects racial backgrounds the same, it evenly affects racial backgrounds. So next are these pictures of what Sjogren syndrome may look like. So the dry eyes and the dry mouth. I have some more pictures later. So just to give you an overview of the two main symptoms, which are dry eyes and dry mouth. So dry eyes are caused by the swelling of the tear ducts, and the chemical structure of the tear is actually altered as well. So not only their tears are different from mine and yours, even when they can produce tears. So that just gives you a little bit of background of the dry eyes. So the dry mouth is typically what dentists or speech pathologists are the first to catch. So it's a decrease in salivary production, and saliva in the mouth is very crucial because it coats the teeth and the gums and wipes away any harmful bacteria that may be in there. So the negative effects of dry mouth can be tooth decay, mastication problems because the saliva isn't there to soften the food and break down the food in the mouth before it's actually swallowed. So swallowing difficulties and chewing difficulties are present. A decrease in taste sensation, increased infection in the mouth. It also impacts the vocal folds, which I will talk about in a little bit. It actually doesn't, the vocal folds aren't moist, so when they hit together, it actually causes irritation on the vocal folds, which I'll talk about later. But dry mouth is all due to a lack of salivary production. So the two communication difficulties that are present with Sjogren syndrome is dysphagia, which is a difficulty swallowing because of the lack of saliva, and chewing difficulties, and then voice disorders for overcompensation of the dry vocal folds, which ultimately leads in leakage of air and a harsh vocal quality. So what does the research say? So this research article was conducted, and the researchers in this article used feast to study the swallowing effects of Sjogren syndrome. And overall, it was found that it was easier for patients with Sjogren syndrome to swallow soft solids because it moistened the mouth. So this study not only proved that dysphagia is present in Sjogren syndrome, but it also proved that soft solids are easier for patients to swallow. And researchers concluded that dysphagia is most likely due to the lack of saliva to moisten the mouth. This next study, researchers used fees to observe the vocal folds during vocal exercises, and the results of this study showed that the vocal disorder dysphonia is present. So dysphonia is the leakage of air, which is caused by overcompensation. So like calluses are produced on the vocal folds, which is causing an excess amount of air to escape from the vocal folds. So this research study does show that dysphonia is present. It is very common in patients with Sjogren syndrome, and it should be addressed. So these next two slides go through the efficacy of Sjogren syndrome and the treatment of voice and dysphagia disorders. So this article compared the effects of vocal function exercises and amplification on patients with dysphonia, and ultimately found that vocal function exercises, so the healthy vocal habits, so diaphragmatic breathing, finding the proper optimal pitch, are all crucial and benefit the patient significantly more than amplification. So the basis of this research article proved that vocal function exercises are efficacious and should be used in a clinical setting. So the efficacy of treatment of dysphagia, this article sought to study how the chin tuck maneuver affect patients with Sjogren syndrome. So chin tuck maneuver is used to clear residue, which can be left in patients with Sjogren syndrome because of the lack of saliva to wash away all that residue, which is anything left behind from the swallow. So this study ultimately saw that the chin tuck maneuver is significant and can be used in a clinical setting and ultimately improve the oral transit time and the pharyngeal delay time. So the chin tuck maneuver is great for patients with excess residue. So this is my fictitious client with Sjogren syndrome and how I would go about treating this patient. So this is a 46-year-old patient, a female. She's complaining of soreness in the muscles, bad breath, dry mouth, choking. She is diagnosed with Sjogren syndrome secondary to rheumatoid arthritis, and she is diagnosed as an SLP diagnosis with dysphagia and dysphonia. So the formal testing materials I would use for dysphagia are a clinical bedside evaluation. So that's just my subjective perceptual view of the oral cavity, how she's chewing, how she's swallowing, just my perceptual recommendations, what I see. I would use a feast study. So that's the camera that goes up the nose and parallel to the lateral pharyngeal wall. To observe any residue, I can measure the amount of residue that's left behind. MBS allows me to view if aspiration is present. So it's like an x-ray view from the sagittal side, so I can view all 4 stages of the swallow and see if there's any aspiration occurring. So I would definitely perform that. Formal testing materials for voice, I would get her background information to identify any vocal abuse, misuse, overuse. I would monitor her words per minute, her S to Z ratio, visi pitch, and I would also use a feast to look at the quality of the vocal folds. So all of these different tests will let me know if there is an excess release of air at the vocal fold level to see if there is a lack of contact between the vocal folds. So all of these vocal assessments I would use. So the plan of treatment, for treatment of dysphagia, because the research does prove, I would use the chin tuck maneuver to be taught, and it's very subtle and can be used in everyday settings. For treatment of dysphonia, I would, because the research approves it, I would I would recommend vocal function exercises, administer diaphragmatic breathing. So these next couple slides are recommendations that I would make for my client. So obviously I would do the chin tuck maneuver. I would request a modification of diet from her physician to more soft solids foods to help moisten the mouth. I would recommend vocal rest if it's approved. I would obviously recommend her to her rheumatologist, a dentist, an optometrist. I would also recommend biotin if it was approved by her physician to moisten the mouth and help with any dry mouth symptoms to help eating be a little bit more bearable. So the long-term goals for dysphagia and voice. So basically dysphagia, we want her to use these compensatory strategies and maintain safety, hydration, and nutrition while consuming the highest possible diet. Voice, Ms. Whitman will demonstrate healthy vocal quality for at least 45 consecutive minutes. So these dysphagia short-term goals and voice short-term goals are my goals that I would make for the patient. So the first dysphagia short-term goal would be to perform the chin tuck maneuver. The second would be to tolerate complex diets without symptoms of aspiration. And then in order to decrease the presence of aspiration, we want her to safely consume soft foods to help with the swallowing process. For voice, we want her to demonstrate proper diaphragmatic breathing. We want her to eliminate and record her elimination of daily vocal abuse and misuse patterns over a 4-week time period. And then we ultimately want her to decrease upper body tension that may be her overcompensating for the leakage of air and trying to be heard. So we want her, that's my last short-term voice goal, is to decrease the presence of those vocal abuse behaviors. So this last slide are websites that I think would be helpful. So Sjogren syndrome offers a lot of information on support groups for Sjogren syndrome, what Sjogren syndrome is and how it could affect you. The Mayo Clinic website I think is great because it really helps the client understand the process that their doctor may be going through. So what they can expect when they go in, what the doctor may be doing. So these two websites I feel like are very helpful and very informative to the patient, and I thought they were very helpful to include even for other medical professionals to gain more information on Sjogren syndrome. Thank you for your time.